In 2010, 25,871 adults across the United States were enrolled in a randomized controlled trial. Half were assigned to take 2,000 IU of vitamin D3 per day. Half received a placebo. The trial ran for a median of 5.3 years. When results were published in the New England Journal of Medicine, the headlines were complicated. The primary endpoints, new cancer cases and major cardiovascular events, were not significantly different between groups. But a secondary analysis told a different story. Cancer mortality was 25% lower in the vitamin D group. If those two findings seem contradictory, they are not. Understanding why they differ is the most important thing this video can give you. In this video, what the VITAL trial actually measured and found, why the primary and secondary endpoints diverged, what other vitamin D evidence shows for adults over 55, and 3 evidence-informed steps for discussing vitamin D with your physician. Quick note before we continue, this is educational content based on published research, not medical advice. Talk to your physician before starting or changing any supplement regimen. Vitamin D supplementation has dose-dependent risks and interacts with certain medications. Now, the study. Vitamin D deficiency in adults over 55 is more common than most people expect. After the age of 50, the skin becomes progressively less efficient at synthesizing vitamin D in response to ultraviolet B radiation. Institutional surveys in the United States estimate that approximately 30 to 40% of adults over 60 have serum 25-hydroxyvitamin D levels below the 20 ng per milliliter threshold that most clinical guidelines define as deficient. An additional portion are in the insufficient range, between 20 and 30 ng per milliliter. As a result, vitamin D is the most commonly used dietary supplement in this age group, often taken without laboratory testing to establish whether it is actually needed. The biology is straightforward. Vitamin D acts as a hormone, binding to receptors found in virtually every tissue in the body, including immune cells, cardiac muscle, and brain tissue. Low vitamin D levels have been associated in observational studies with higher rates of cardiovascular events, certain cancers, cognitive decline, falls, and fractures. But association in observational studies is not the same as causation in a randomized trial. The VITAL trial was specifically designed to test the causal question. VITAL stands for Vitamin D and Omega-3 Trial. It was a 2x2 factorial trial, meaning participants were randomized across 4 groups: vitamin D plus omega-3, vitamin D plus placebo, omega-3 plus placebo, and double placebo. For today's video, we focus on the vitamin D comparison. The intervention was 2,000 IU per day of vitamin D3, the same cholecalciferol form found in most over-the-counter supplements. Participants were men aged 50 and older, and women aged 55 and older, reflecting the differential risk onset for cardiovascular disease between sexes. The average age at enrollment was 67. An important detail about the population: the average baseline 25-hydroxyvitamin D level at enrollment was approximately 31 ng per milliliter. That is technically sufficient by most clinical guidelines, not deficient. The researchers were testing what supplementation does in a broadly healthy population, not specifically in people with confirmed deficiency. This is a critical point for interpreting the results. We are looking at what happens when you add 2,000 IU per day to people who were, on average, not severely depleted. The primary endpoints were total invasive cancer incidence and major adverse cardiovascular events, defined as the combination of heart attack, stroke, and cardiovascular death. After 5.3 years of median follow-up, neither primary endpoint showed a statistically significant difference between the vitamin D and placebo groups. Cancer incidence, hazard ratio of 0.96, not significant. Major cardiovascular events, hazard ratio of 0.97, not significant. For many readers, that was the end of the story. But the pre-specified secondary analyses revealed a more nuanced picture. Cancer mortality was a pre-specified secondary endpoint. In the vitamin D group, cancer mortality was 25% lower than in the placebo group. The hazard ratio was 0.75, with a 95% confidence interval of 0.58 to 0.97. That interval does not include 1, so the finding is statistically significant. The researchers also observed that the benefit in cancer incidence grew stronger in later years of follow-up, after the first 2 years were excluded from analysis. Among participants with at least 2 years of follow-up, the hazard ratio for cancer mortality was 0.74. A second pre-specified secondary analysis looked at advanced cancer, defined as metastatic or fatal cancer. Published in a follow-up paper in JAMA Network Open, advanced cancer incidence was 17% lower in the vitamin D group, with a hazard ratio of 0.83. The 95% confidence interval for that finding just touched 1.0, making it statistically borderline, but the direction was consistent with the cancer mortality result. Across the full vital analyses, the picture that emerged was no reduction in total cancer cases, but a possible reduction in cancer deaths and advanced cancer cases among those who developed cancer. Why would vitamin D reduce cancer mortality but not cancer incidence? One hypothesis is that vitamin D does not prevent initiation of cancer but influences tumor biology after a cancer develops, perhaps slowing progression or metastasis. Another is that the 5-year trial was simply too short to detect a reduction in incidence, because cancer takes longer to develop than cardiovascular events. A third hypothesis is that at an average baseline of 31 Ing per milliliter, the participants were not vitamin D deficient enough for a preventive effect to emerge. People with true deficiency at baseline may respond differently. Now for the limitations. First and most important, cancer mortality was a secondary endpoint, not the pre-specified primary outcome. When researchers test many secondary endpoints in a trial, the probability of at least one appearing significant by chance increases. The vital investigators were careful to pre-specify their secondary analyses, which reduces but does not eliminate this concern. Interpreting a significant secondary endpoint requires more caution than interpreting a significant primary endpoint. The finding is hypothesis-generating and clinically plausible, but a replication study in a vitamin D deficient population would substantially strengthen it. Second limitation: the population was predominantly non-deficient. VITAL enrolled a broadly healthy, largely sufficient population. The findings from VITAL tell us what 2000 IU does in people with average baseline levels of 31 Ing per milliliter. They do not tell us what vitamin D supplementation does in people who are genuinely deficient, at levels below 20 Ing per milliliter. Those are different questions, and they may have different answers. Third, the trial did not adjust supplementation dose to achieve a target blood level. Some participants may have needed higher or lower doses to reach a clinically meaningful threshold. A fourth limitation: VITAL was powered for hard cardiovascular and cancer endpoints over 5 years. Slower developing outcomes, such as cognitive decline, fracture risk, or autoimmune disease, were not primary endpoints and would require longer follow-up and larger sample sizes to assess definitively. The vitamin D literature has trials suggesting benefits for bone health and fall reduction in people who are deficient, but those are separate questions from what VITAL addressed. 3 evidence-informed takeaways for adults over 55. First, know your level before supplementing. A simple serum 25-hydroxyvitamin D test is available through standard blood panels. Most laboratories report results in Ing per milliliter. The Endocrine Society defines sufficiency as above 30 Ing per milliliter. Levels between 20 and 30 are considered insufficient. Below 20 is deficient. If you have not tested recently, asking your physician to add this to your next standard blood work is a reasonable starting point. Supplementation needs look very different if you are at 15 versus at 45 Ing per milliliter. Second, if your level is below 30 Ing per milliliter, discuss supplementation with your physician. The dose studied in VITAL was 2000 IU per day, which is within the range most physicians consider safe for adults who are not significantly deficient. However, doses above 4000 IU per day carry risk of toxicity at certain baseline levels, and vitamin D interacts with thiazide diuretics, some heart medications, and other supplements. This is not a decision to make based on a YouTube video. It requires your actual lab values and a conversation with your physician. Third, diet and sun exposure remain foundational. The foods richest in vitamin D are fatty fish, such as salmon, trout, and sardines, egg yolks, and fortified dairy or plant-based milks. Brief midday sun exposure without sunscreen, even 10 to 15 minutes on arms and legs in summer, contributes meaningfully to vitamin D status. These sources will not replace supplementation if you are genuinely deficient, but they establish a baseline that reduces the gap you are trying to close with supplementation. To summarize, the VITAL trial, the largest randomized vitamin D trial ever conducted, found no significant reduction in cancer incidence or cardiovascular events with 2000 IU per day over 5.3 years in adults averaging 31 ing per milliliter at baseline. A secondary finding showed 25% lower cancer mortality in the vitamin D group, with a statistically significant hazard ratio of 0.75. That finding is meaningful but requires cautious interpretation as a secondary endpoint in a largely sufficient population. This is educational content, not medical advice. Always consult your physician before changing your supplement regimen. Individual responses and baseline levels vary substantially. Download our free biomarker guide in the description for a section on interpreting your vitamin D panel. New evidence reviews every Tuesday and Friday.